the cases to the patients, and I'll put the groups together. I'll either send them out later today or tomorrow afternoon, tomorrow morning. Depends on how long it takes me to type it in. So now we're going to talk about shoulders. To me, shoulders are a lot more interesting than back and neck. The shoulder is really a complex joint. It's the most mobile joint in your body. There's a lot of anatomy there. But it's a lot easier to recognize a problem going on in a shoulder and know what's going on than it is in a neck or a back. So it's one of the more common complaints you're going to get in primary care, family practice, emergency medicine, orthopedics. It can either be due to an injury, any kind of acute or chronic inflammation. It can be the tendons, it can be the joint, it can be any of the surrounding ligaments or any of the periarticular surfaces or structures. It can also be a referred pain from the neck, so that's one thing you always got to look at. That's where it gets back to my joint above to joint below, the area of pain or the area of injury, because you never really know where it's coming from. It's got, like I said, the most range of motion of any joint in the body. So the anatomy consists of 3 bones: the humerus, the clavicle, and the scapula. And all the articulations come from these. So when you're looking at it, your clavicle it articulates at the sternum, so you get the sternoclavicular joint, comes out and articulates with the acromion process, and then the humeral head articulates with the glenoid fossa. So that's where a lot of the range of motion comes from, but there's also the scapula, which allows for elevation. So the 4 articulations, the glenohumeral joint, it's a ball and socket type joint. The bulk of the motion is going to occur here. 2/3 of the shoulder motion comes at the glenohumeral joint. There's the scapulothoracic, which elevates the arm, and it's 1/3 of the rest of the 1/3 of the shoulder motion from the joint. There's the acromioclavicular joint. That's where the acromion meets the distal clavicle. There's little or no motion there. And then there's the sternoclavicular joint, which is the proximal articulation of the clavicle with the sternum. And again, there's little or no motion. So going back to the anatomy, there's ligaments that attach at the AC joint as well as down here that attach the clavicle to the coracoid and the coracoid to the acromion. So in the shoulder girdle, it's the most mobile joint in the body. The humeral head articulates with the glenoid fossa. The glenoid fossa is about 1/3 the size of the humeral head. So this gives you a lot of that range of motion because it's such a shallow socket. It's a stable joint, but it's dependent on the capsule, ligaments, and the rotator cuff muscles to keep it in place. So you've all learned the rotator cuff muscles. You know, the acronym is SITS: supraspinatus, infraspinatus, teres minor, and subscapularis. The rotator cuff muscles make up the intrinsic muscles of the shoulder. The tendons come together and form almost a common tendon. The supraspinatus is the most distal. It's also the most superior muscle, and it's the one that's most susceptible to injury. The subscap is an anterior muscle of the cuff, and it acts as an internal rotator. So internal rotation is when you're reaching in behind your back. The infraspinatus is a posterior muscle, and the teres minor is also a posterior muscle, and acts with the infraspinatus as an external rotator. So when you're reaching out or reaching like this, that's external rotation. So this is a pretty good picture of all the muscles. When you look at the tendon of the rotator cuff tendon, it actually comes right in underneath the AC joint. So if people that do a lot of overhead work, that tendon keeps coming up, and it's hitting the underside of the acromion process. So over time, you can develop spurs. You see it in people that do a lot of overhead work will develop spurs on the underside of the acromion process. So the extrinsic muscles, in coordination with the rotator cuff muscles, move the humerus. And the extrinsic muscles include the deltoid, the pec major, latissimus dorsi, and teres major. The bicep muscle is also included in there because the origin of the biceps is on the humeral head. It acts as both an intrinsic and extrinsic type muscle. The intrinsic function is to stabilize the glenohumeral joint anteriorly, and the extrinsic function is to flex the elbow. It's important in throwing and any overhead motion. The scapular muscles contribute to the shoulder function. The primary muscles are the serratus anterior and the trapezius muscle. Winging of the scapula is most often occurs as a result of a neuroinjury, usually the long thoracic nerve, but it can be due to a primary muscular weakness as well. In neuroinjuries of the shoulder, there's 5 peripheral nerves that can be injured and affect the shoulder function. The major peripheral nerves are the axillary nerve, which affects at the C5-6 level. The subscapular nerve is also C5-6, and the musculocutaneous nerve is C5-6. The long thoracic nerve innervates C5 through 8, and the spinal accessory nerve innervates C3 through 4. So injuries to the axillary nerve are the ones that are most commonly occur. It usually comes with anterior dislocation, which is about 90 to 95% of all shoulder dislocations you're going to see. The weakest point in the shoulder is at the front. So you see these people where they're falling and they grab onto something, and there's a quick movement to move their arm back where the humeral head comes forward in the glenoid and it pops out. Usually when people have these dislocations, you can see them sitting right here. You can see the humeral head sitting right here. And I teach the nurses at the hospital that do triage, if they think it's a shoulder dislocation, just take your finger and push where the humeral head should be. If your finger starts to disappear, it's probably a dislocation. It's just a simple little trick, because they're all freaking out because they think half these people have dislocations and the majority of them don't. So I just keep telling them, just push there. And that's a little trick to know. It can also, getting back to the axillary nerve, I kind of got off on a tangent there. The axillary nerve can also be injured with the brachial plexus type injuries or any compression of the shoulder during surgery. It affects the deltoid function, so the weakness results in an inability to abduct or to lift your arm away from your body. It also affects the teres minor function, so that's external rotation weakness, but that can be compensated for. So can the weakness in the deltoid. You'll see people that have that weakness in the deltoid, instead of doing a strict abduction, will do this, where they throw their arm up, but as they throw their arm up, it comes right back down. There's also sensory loss over the deltoid, and it's most profound in a 2 to 3 centimeter area over the deltoid insertion, so right down in this area here. So you should take your Q-tip or your finger and just drag it across that whole area when you're looking for the function. No deep tendon reflexes are affected. Suprascapular nerve injury can occur with a fall on a posterior shoulder, any type of a stretch injury or a fractured scapula. Signs and symptoms mimic a rotator cuff injury. The history and mechanism of the injury are the most important in distinguishing between the two. It's seen in patients who do overhead throwing, so people that pitch, people that throw the javelin, people that throw the shot put, things like that. Most of these people present with posterior shoulder pain and weakness in the shoulder in abduction and external rotation. No deep tendon reflexes are affected. Musculocutaneous nerve injury is rare. It's usually from a direct trauma with a humeral fracture or along with a brachial plexus type injury. Usually you get weakness in the biceps and the brachialis muscle that results in a weakness of elbow flexion. You'll get decreased sensation or loss of sensation on the thumb side of the forearm. And the biceps deep tendon reflex is affected with this. Long thoracic nerve injury isn't very common, but this is the one that you'll see the scapula winging in. It usually occurs from repetitive microtrauma with heavy effort above the shoulder, like shoveling, chopping, carrying a heavy backpack. It's a weakness of the serratus anterior muscle that results in the scapula winging, and they have a hard time abducting past 90 degrees. There's usually no DTRs or sensory affected with this. The spinal accessory nerve usually comes with an injury to the neck. It's most often injured due to a poorly fitting type backpack. The injury occurs distal to the cranial nerve, and a portion of the sternocleidomastoid muscle is not affected, but the trapezius is affected. Shoulder shrug is what's diminished on the affected side, and difficulty with abduction greater than 90 degrees. There's no significant sensory disturbance except the shoulder is painful. and there's no deep tendon reflex abnormalities. So bony trauma is what you're going to see a lot of, especially in emergency medicine and orthopedics. It can be fractures, it can be fracture dislocations, or it can be acute dislocations that will lead to an anterior instability of the anterior or posterior instability of the shoulder. So fractures of the shoulder should be immobilized and referred to an orthopedist for evaluation and appropriate treatment. The clinical presentation is variable sometimes, but it's usually a traumatic event with significant pain. A lot of times it is ecchymosis or bruising. Usually there's some swelling. Sometimes it's hard to differentiate swelling, though, in the shoulder because you get people that are bigger and you're not sure. That's why you got to compare side to side. The swelling can go down into the upper arm, though, by gravity. The likelihood of shoulder and proximal humerus fracture increases in the elderly, especially with the incidence of osteoporosis. The cornerstone of the X-ray diagnosis is the near trauma series, and that includes an AP view. So when they're shooting from front to back, so the beam goes front to back, as well as the lateral or the Y view. The Y view is always going to be your money view for dislocation. When you look at a shoulder X-ray from the side, there's going to be a Y, and if any part of the humeral head is in that Y, the shoulder can't be dislocated. And there's also an axillary view where they kind of shoot up. Sometimes they call it an oblique type view. 85% of all shoulder fractures are non-displaced or minimally displaced and usually can be treated with a sling. So this is a normal shoulder X-ray. This is your AP view here, and this is your Y view. Actually, this is your axillary view. This is telling you the difference. This is considered a normal shoulder X-ray, but if you look at this one here and you look where the humeral head is sitting here, and then look at how high it's sitting here, anytime you start to see that humeral head that's up this high and it's overlapping, then you should think about a rotator cuff type injury, because they shouldn't be down there. You should see more of an articulation with the glenoid, and this is sitting up kind of high, so you should think about a rotator cuff injury. A lot of times these will be called normal shoulder X-rays. But you should, if you see that, you should really think about a rotator cuff injury. It's because the cuff's torn and it lets it rise up. The cuff helps to stabilize the joint, so it keeps the humerus down in the joint. Once the cuff is torn, now it can ride up high. So most of the fractures of the shoulder are treated with conservative treatment with a shoulder immobilization, just a sling. You don't want, if they've got a fractured shoulder, the last thing you want to do is put that strap around their waist, because now you've locked them in. You really want to let the sling be on there, and you want to let gravity do the work. You want gravity to act as your traction to pull it down to semi-reduce the bone. It depends on the age group of these people. Some people, the younger people, they're more likely to do surgery on. But you see this a lot in the elderly people, you know, the 75, 80, 85, 90-year-old people. The risk of surgery for those people is a lot higher than somebody, you know, in your guys' age group. So they'd be much more likely to do surgery on a younger person than they will somebody older. If it's somebody older that's very functional, in good health, they're more likely to do surgery to reduce it. But for the most part, you treat it conservatively. The drawback to it is they're going to lose function. They're going to have limited range of motion of their shoulder, because where that fracture is where it's going to heal. So unless it's in perfect alignment, you know, and it's just a tiny crack, they're going to lose function. So after about 10 to 14 days in the sling, you want to have them doing what's called pendulum exercises, where you have them just kind of bend over and just let their shoulder go in circles. Go counterclockwise and clockwise. And what that does is it doesn't let the shoulder stiffen up too much. Remember, it's the most mobile joint, and it will become stiff really quickly if you just keep it immobilized. That's a big thing to know. It's people that stay in that sling forever usually have a frozen shoulder afterwards. So when you're looking at fractures of the shoulder or the proximal humerus, this is the near classification system. If you guys can just remember 2, 3, and 4 part fractures, you're good. You don't have to remember all of that, but just remember 2, 3, and 4-part fractures. Usually the ones that are 2-part heal relatively well. The ones that are 3-part are usually the ones, 3 and 4-part are usually the ones that you're going to have surgery with. And the 4-part ones are more likely to be dislocated. Although it can happen with the 2 and the 3. So there's also 1-part fractures where there's no displacement. And then there's 2-part fractures where you actually see separation between them, and one fragment is displaced, whether it's the proximal fragment or the distal fragment. Usually what you base it on is the proximal fragment in the shoulder when you're describing a fracture. So if you said to me, I've got this guy that came in, fell off a ladder, he's got a 2-part fracture of his proximal humerus, you would want to say to me that the proximal fragment is displaced in relation to the distal fragment. So that's how you do it. Whereas in the wrist, it's going to be reversed. It's the distal fragment to the proximal fragment. With the 3-part fractures, 2 parts are displaced, and the humeral head usually remains in contact with the glenoid. So you want to get all those, you want all 3 views. You want that Y view to make sure that that's still articulating with the glenoid. In the 4-part fracture, that's usually with the dislocation. There's 3 or more displaced fragments and a dislocation of the articular surface. Sometimes it's hard to see on the x-ray, and you're going to need a CAT scan. So if you have any question of a dislocation with a 4-part fracture, just get a CAT scan too. Because if you leave them dislocated, there's more risk for neurovascular injury as well. So this is a simple 2-part fracture here. So the way you would describe that is a fracture of that's probably the humeral neck with the proximal fragment displaced about 25% medially and angulated inferiorly. That's how you would describe that. On this one here, it's minimally displaced laterally, probably 15 to 20%, but it's in good position. Again, these are pretty much similar films here. You can see this one here, this is impacted. So this is somebody that probably landed on their elbow. You can see the outline of the humeral neck and how it looks like it's pushed up into the head. This looks like it's probably a 3-part fracture because you can see the line coming down through here. So here's 1 fragment, here's 2 fragments, and this would be the 3rd fragment here. If you look over here on this one looks like it's displaced laterally. So this is probably a 2-part fracture, but the head is just right off. If you look at it like an ice cream cone, the head should be sitting on top. But when your ice cream starts to melt and the head of the cone comes off and starts to slide down the side. It's not, that's a shoulder.
I know, but I'm saying like...
Trauma. Fall. Most of the time, the way you either fall directly on it or you land on your elbow, and the humerus the weak point is up here, so all the force transmits up. It snaps off, and the lower fragment just drives itself up into the head. The more complicated fractures can require a percutaneous pinning, an ORIF, which is plate and screws, or an IM rod, or sometimes a hemiarthroplasty. When you hear the word arthroplasty, that means joint replacement. So usually when you hear joint replacement, it's 2 surfaces that are getting replaced. But if you hear hemiarthroplasty, it means that only one joint surface was replaced. Usually in this case, what you do is you use a saw and you leave like half a centimeter of the surgical neck of the humerus, and you cut off the head of the humerus, and then you put a prosthesis in that will have a ball that will articulate with the glenoid. So it's a pretty cool surgery. It's nowhere close to catching up with hips, but it's better than nothing, because if you don't fix that, they're not going to have hardly any range of motion at the shoulder. So this is an ORIF. You can see there's the fracture line. right there. So I'm guessing with this that this fragment was displaced. It looks like there might have been another fracture up here because of the way this screw comes up to try and get the fragments. It's an awful lot of screws, though. This is an IM rod. So you can see here's the fracture in the proximal humeral shaft. So what they do is you open up the top here, and you distract the shoulder out, and you have like almost like an awl, and you tap your hole in the humeral head, and then you drill a little bit to bore out the shaft down the shaft, and then you tap your IM rod down. The hard part is aligning the fractures without rotation. The other thing with this fracture here is your radial nerve and your this fracture right here, your radial nerve and your radial artery are pretty close in that area. So the one thing you got to make sure is that they have good neurovascular function. And you hope, because you can't see it, you hope that as you're driving that rod down, none of the radial artery or radial nerve is in that shaft. We had a guy, I actually saw him yesterday, he came for a cortisone shot in the ER. He fell off of a ladder. He fell about 6 to 8 feet off of a ladder, landed on his right arm. He came in, it looked like his proximal humeral shaft had just exploded. It was in about 5 pieces. And we were so worried. He had good neurovascular function, but we were so worried that we would catch, because of all the fragments, that by putting a rod down, that we would catch the nerve or the artery in the fracture or hit it with the rod. What we did is we took him to the OR, and we did what's called a closed reduction. So I basically just grabbed onto his arm and pulled down so that under fluoroscopy we could see the fracture reduce. And then the orthopedic surgeon put the splint on, and I just basically stood there and leaned back to keep the traction on it. And it held, because he walked in yesterday, he was like, hey, look it, still works great, you know. So, but it did. I mean, it was like, we were freaking out about that. We x-rayed him every week. And we were like, if you feel anything, any numbness, anything, call us. So you can kind of see, here's the finished rod right here. And these are healing fractures. You can see the callus that's formed. This fracture is pretty well healed. These rods are stainless steel, so they're pretty tough. Either stainless steel or titanium. It depends on which one you get. This is a hemiarthroplasty. So you can see what they do is they cut off the neck here, the neck and the head, and you just drive a little prosthesis in. They're very similar to total hips. The technology isn't there yet, but it's getting there. The shoulders are getting much better than they were. 10 years ago, hemiarthroplasties and shoulder replacements sucked. They were awful. They had limited range of motion. If you had a torn rotator cuff, you were done. Now they have reverse shoulders for people that have torn rotator cuffs. I think I have a picture in here of that too. So with fracture dislocation, the treatment is determined by the extent of the injury. Some of these require closed reduction and immobilization. Some require surgical intervention. And you got to make sure that the glenoid and the humeral head destruction isn't so severe that it's going to require a total joint. Because sometimes when you get these fracture dislocations, sometimes you'll also fracture the glenoid, especially the ones that the humeral head gets driven up into the glenoid joint. And the head will shatter, plus you'll get a fracture of the glenoid as well. Those are the ones you got to do a total shoulder on. So the humeral shaft fractures, they can be proximal, mid-shaft, or distal. The majority of the proximal and mid-shaft fractures are non-displaced and treated conservatively. They typically result from trauma such as a direct blow or some type of bending or shearing type force to the humerus. And less commonly, if on a fall on an outstretched hand or a fouche type injury or landing directly on the elbow. Sometimes these can result from a strong muscle contraction with a high velocity. I don't know if everybody here has seen it, but there was a pitcher for the Giants a few years ago who threw a pitch, and you could see his arm just snap in two. And it just let go. And that was from such a force of throwing the ball. So, yeah. I have to wonder, was he on steroids? So, they typically present with severe arm pain. It can be referred to the shoulder or the elbow. Usually there's localized tenderness to palpation at the fracture site, a lot of swelling, a lot of ecchymosis. Sometimes if you see shortening of the arm, that will tell you that the fracture is displaced. Most of these people will come in holding their arm, like cupping their forearm, and they don't want you to move it. Because when you have these type fractures, if you pull on the lower arm, what you're doing is you're levering the fracture. So it's bending the fracture. So that's the one thing that guy talked about yesterday. His daughter drove him to the ER, and he said his daughter was getting sick because every time she went over a bump, you could hear the bones crunching. So he said he thought his daughter was going to throw up. She kept like looking away. He was like, just look, just watch where you're going, just drive. So you really need to do a good neurovascular exam on these people. You need to include the radial and ulnar arteries as well as the radial and the median nerve. The radial nerve is the most commonly injured, and it results in a weakness of the wrist and fingers and thumb extension. So when you got these people, you always want to make sure they can flex and extend their wrist, flex and extend their thumb, and flex and extend their fingers, especially at the MCP joint. Sometimes they'll have elbow weakness with extension, but that's hard to determine in the acute phase because most of the time they're not really going to want to move that elbow because it's too much pain. And there's injuries to the median and ulnar nerves, but they're much less common. These fractures can be either spiral, oblique, or transverse. Usually the transverse fractures are simple type fractures. They don't really require any traction. You place them into a sugar tong type splint, which starts up here and wraps up. You want to get as high in the axilla as you can. Put them in a sling, let gravity do the work. You're going to x-ray those people every 2 weeks and follow it, make sure it's not displacing. You should start to see some bone healing on the x-ray, a little bit of callus formation at about 4 weeks. Most times when you get x-rays at week 2, it's just to make sure that they've maintained the alignment. At week 4, that's when you'll start to see a little bit of x-ray, unless it's a kid. A kid, you may start to see it at 2 weeks, but an adult, you're not going to see anything on no callus formation before 4 weeks. Within 1 to 2 weeks, you should have them take their arm out of the sling and do the pendulum exercises with the shoulder so that they don't stiffen up. They've also started making these neat little plastic braces. So instead of putting the splint on them, usually they'll put the splint on in the ER, and then they'll come into the orthopedic office, and we call the brace guy. And they have these plastic braces that they're hinged with plastic, and they cup around, and then they're tied down with Velcro straps, and that acts as like your splint. So not every place has those. They're kind of expensive, and not every insurance pays for them. But if you can get somebody into that, they're a lot more comfortable in that than they are in the splint. And you don't have to worry about an ulnar nerve or a radial nerve injury in the elbow because it doesn't include the elbow. The spiral and oblique fractures, they usually require some sort of traction, usually what's called a hanging cast or a coaptation splint. Hanging cast and coaptation splint is that sugar tong type splint I talked about, plus a posterior splint. So what you're doing is you're getting them both ways. You're keeping their elbow flexed at 90, and you want their hand in neutral, so with the thumb up, hand and forearm in neutral. And what that does is you put added weight on there from the weight of the splint, and that acts as your traction to keep it down. If you do put a cast on these people, which I don't recommend, you'd need to bivalve the cast because you've got to allow for swelling. Their hand is going to swell overnight. And if you put a long arm cast on these people and then send them home, I'll guarantee you they're going to be back within 24 hours because it's so swollen. It's going to be too tight. You have to allow for swelling. And if they leave it on and it's too swollen, then you can get neurovascular compromise. So like I talked about, the weight of the splint of the cast is going to act as your traction to keep the fragments reduced and in place. The follow-up, again, is usually done every 2 weeks with the x-ray. In displaced fractures, like we showed on the x-ray before, some of those need an IM rod. Clavicle fractures. The clavicle is the only rigid bony connection between the shoulder and the chest. Its function is to hold the shoulder up and back. It's the most commonly fractured bone in children. Usually there's tenderness to palpation at the fracture site. There can be an obvious deformity with tenting of the skin. They're usually pretty easy to see when they're like that. Neurovascular disorders are usually rare in these. Usually we treat them with a sling. They used to have these clavicle straps which pulled you back, and usually it went over the fracture site, the two straps. People were so uncomfortable in those because now you're putting pressure on that fracture site. They do much better with just a sling. As long as the bones are touching or articulating, as they say, it's going to heal. If the bones are displaced and not touching, those are the ones you've got to treat surgically. So you can kind of see this guy here. He's obviously got a distal 2/3 clavicle fracture with tenting of the skin. This is displaced superiorly. Here's an x-ray. These are the ones you usually see. They kind of like bend. This will heal nice. They'll have a little bump there for the rest of their life, but the bone will heal because bone is unique. Every other part of your body heals with some other type of structure. With a bone heals itself with bone. It's the only thing that will regenerate itself. So this is a displaced one, but this will heal. This is technically a 3-part fracture. This might be one that they would take to the OR. Even though it's touching and it's shortened a little bit there, you've got this free fragment, and you always worry about free fragments. So in the last probably 5 or 6 years, this is probably in 4 pieces because this is a butterfly fragment here. They've come up with these neat little plates for these where the surgical wound is about 1.5 centimeters long. And you do it right over the fracture site. You reduce the fracture. You take out any loose fragments, and it's either a 3 or a 4 hole plate, and you want to get at least 1 screw on either side. All you're doing is maintaining the length. This isn't going to be structural, and then usually they'll leave it in for about a year. A lot of times they like to take them out because people don't like it because once it heals, there's usually the bony fragment, and you can actually, on some people, see the outline of the plate. A lot of people like to come in and have those taken out. Same with the ankle, they like to have those taken out. You know, is it going to hurt you to leave it in there? No. You know, is there a risk of infection? Minimal. Scapular fractures are kind of unique fractures. They always come from a high-impact, high-energy type injury. So big-time motor vehicle accidents. I remember one of the Bruins years ago, Don Sweeney, got hit from behind and ended up with a scapular fracture. So it's a real high-impact type injury. And the people that have these, they're in agony when it first happens. Sometimes you need to get a CT to make sure there's no displacement or a comminution of the fracture. Usually these fractures don't involve the glenoid and can be treated with a sling, but if they do involve the glenoid, that's when usually you go in and you plate them. You should have gentle range of motion. Should begin with as soon as possible, as soon as they can avoid it. As soon as they can tolerate it. So these are classifications of the scapulas. I don't expect you to know these, but it's something to look at. So here's a scapular fracture here. It's minimally displaced laterally. So this is the proximal fragment here. You can kind of trace it up this way. So you can tell what a high impact that takes. This is another one right in here. This is displaced. Shoulder dislocations account for 50% of all major joint dislocations. Anterior dislocations the most common. It's going to occur in about 95 to 97% of cases. The posterior dislocations account for about 2 to 4%, and inferior dislocations for about 0.5%. In the anterior shoulder dislocation, the mechanism of injury is usually a blow to the abducted and externally rotated shoulder and extended arm. So they're out like this, and they get some type of motion that pulls it back that way, so it comes anteriorly. I've seen it in people who fell and grabbed onto things that probably had a weak joint to begin with. It's less commonly caused by a blow to the posterior humerus or a fall on an outstretched arm like that. They usually come in holding their arm like this. They're a little abducted, a little externally rotated. and they don't want you to move them. Because a lot of these people come in, they're gray, they're diaphoretic, and all they want you to do is put it back in and give them some pain medicine. So when you're looking at them, the acromion usually will appear most prominent, and there's usually a loss of the normal rounding of the shoulder. If you push it, like I talked about earlier, if you push over where the humeral head is, your finger starts to disappear. It just feels soft. You should always do a neurovascular check with these, and attention to the axillary nerve, which is a loss of sensation in the deltoid area. It's usually present in about 42% of all these patients to some extent, and it will come with deltoid weakness sometimes even after you do the reduction. And you always want to check the radial and ulnar arteries. The neurodysfunction usually will resolve, but in some cases it does last, sometimes longer. A lot of times it depends on swelling. With these anterior dislocations, you can get fractures that are going to occur in about 25% of the shoulder dislocation. A Hill-Sachs deformity is a pretty common one of these. It's a cortical depression in the humeral head that's created by the glenoid rim as the shoulder dislocates. It's going to occur in about 35 to 40% of all the anterior dislocations. There's also Bankart lesions that occur when the glenoid labrum, which is the cartilage of the glenoid, avulses, and that usually occurs when you look at it. When you look at a Bankart lesion, it's usually in the 3 o'clock to 6 o'clock. If you're looking at the glenoid as a clock, it'll be in the inferior right lower corner. Soft tissue Bankart lesions with no avulsed fracture can occur in about 90% of the patients younger than 30 with anterior dislocation. So these people will tear the cartilage of the glenoid. Sometimes these people will end up developing arthritis because you've torn the articular cartilage. And greater tuberosity fractures are present in 10% of all patients with anterior dislocations. So when you're looking at somebody with an anterior dislocation, here's your acromion. See how prominent it is? So you see what I mean? If you stuck your finger in there, here's his humeral head. Right in here, you can kind of see it. So this is an anterior dislocation. This is where you'll commonly see it. This is the glenoid right here. This is kind of outlining it for you as well. This is the glenoid right here. Here's the humeral head, so it's anterior to the joint. This is a Hill-Sachs deformity. So what happens is as the head comes anteriorly, it will hit the rim of the glenoid, and it will put that depression in it. You can see this is a Bankart lesion here. See the avulsed fragment right here, right at about 3 o'clock, down towards 6 o'clock. And you can kind of see it a little better here. The treatment for anterior dislocation is usually closed reduction with conscious sedation. You can do these without giving them the conscious sedation. I've done them on the football field. One little trick is to get them to hyperventilate. And you get them to hyperventilate, you're putting traction on their arm, pulling it down. And as they get to the point where they're just about to pass out from hyperventilating, you just take it and whip it right up, and it goes back in. So they scream. They're like, ah, ah, ah. Oh, that feels better. So, I mean, they're in agony, so a lot of times they'll be begging you to put it back in. You know, just do it, just do it. So, I mean, I've done it a few times. A couple of times it wouldn't go because I couldn't get them to hyperventilate enough. But it's a little trick that it's, you know, cheap conscious sedation, I guess. So. And you don't have to do informed consent. But you should, if you're going to do conscious sedation, usually you have to get informed consent, because sometimes these people, if you give them a little bit too much on the conscious sedation, are going to end up intubated for a couple of hours, and they're not going to be happy about that, but you have to let them know that. So anytime you're going to do a procedure, you're going to want to get what's called informed consent and get them to sign it, or get a family member, if they can't sign it, if it's their right hand and they're right-handed, get somebody to sign it, or say, write on it, patient unable to sign, and then you have to have somebody witness it, saying that they gave verbal consent. So that's one thing, medical legal, to always remember is get that informed consent. And also with the conscious sedation, you want to, there's usually a form you have to fill out saying what type of oropharynx they have and what type of tongue they have. It's usually 4 categories. Usually if you get to category 4, they're a lot harder to intubate if you have to do it. So you're hoping that they're 1, 2, and 3. Well, there's people with real thick tongues. There's people with small tongues, people with small oropharynxes. Usually the people with the shorter necks have a smaller oropharynx. They're a lot harder to intubate than somebody, that just is normal size. People, the guys, like their heads sit on their shoulders. Right. Those guys are a pain to intubate. Even though now they got these things called glide scopes, and they have little scopes that you can stick down there and just follow along so that you can see the trachea and hit the trachea. Because most times when you're doing a regular, you guys will see an ACLS when you're doing a regular intubation. It's even though they tell you you should visualize the chords, doesn't always happen. Most of the time when you're intubating blind. But now they got these little scopes now that are really neat. You can put it down in there, and all you got to do is look at the TV and pass it right through the cords. It's a lot easier than trying to suction everything out of the way, and it's just painful. There's multiple methods of doing it, and there's no clear-cut advantage. Everybody has the one that works for them the most. The one I use is just to put traction on the arm and just bring it straight up. There's other ones where you have counter traction from the other side. So somebody's pulling this way, and you just grab onto the hand, and you abduct them to 90, and you kind of lean back, and gradually the muscles will relax, and it'll pop back in for you. There's all kinds of them. I don't know if I put any pictures. Yeah. So this is one here. Some people like this. You lay them on their belly. Depending on how big they are, you give them anywhere from a 5 to a 20-pound weight, and just let the dislocated arm hang over the side. Gradually, those muscles will weaken, and it will pull it right back into place. This is the one I like here. I just kind of take them and whip their arm up. This one here, you need 2 people for. This one here, if you've got somebody that can push down, like on here, not in here where the shoulder's dislocated, but on the outside of the shoulder, it's a lot easier to get. So this one here, this is the counter traction here. And this is, you have them laying flat, but your counter traction would be going that way. And you just kind of grab on and hold and pull. And eventually, once you get the conscious sedation to kick in fully, they become fully relaxed, and it just goes right back in. I have them breathe really fast and hyperventilate. If I'm doing it on the football field or at a hockey rink, yeah. I get them to the point where they're going to pass out from hyperventilating, and then I just whip their arm up. And they're ready to hit me, but then it feels better in 2 minutes. So, what's that? No, you shut them down. You shut them down because they're in a lot of pain, and usually they're begging you to do it. So,
Isn't there a risk if you leave it out of the socket?
right, neurovascular risk. The longer it's out, yeah. But also, the longer it's out, the more muscle spasm you get, the harder it is to get it back in. If you can get them right away and get it back in, they don't have as much muscle spasm. But once that muscle spasm kicks in, I've seen people even with conscious sedation that we've had a hard time getting back in. Sometimes you have to take them to the OR and put them under general anesthesia and pavulinize them, which just relaxes all their muscles. And then you can get it back in. But if you can get it back in without giving them conscious sedation, you've eliminated that risk of conscious sedation. Because people react differently to the drugs you use. You try to use short-acting stuff like etomidate. What's the other one? I can't think. There's a whole bunch of them. There's Norcuron and stuff like that. There's a whole bunch of them that people use. But you want to use one that has like etomidate has a 3 to 5 minute half-life. So usually within 10 minutes they're waking up. So. And you always have to monitor them. When you give them the conscious sedation, they always have to be on a monitor. So you have to be able to see their heart rate, and you have to be able to see their O2 sats. And you always want to have oxygen in the room. The face mask, the 100% non-rebreather. Unless they're a COPD, you want to have that 100% non-rebreather on them while you're doing the procedure. Posterior shoulder dislocations are less frequent. The mechanism is a blow to the anterior portion of the shoulder, so you're pushing front to back. Some type of axial loading of the arm when it's in adducted position and internally rotated. or some type of violent muscle contraction following a seizure or an electrocution. I've seen plenty of people with seizures that come in with posterior shoulder dislocations. Usually the exam, you'll see a prominence in the posterior shoulder and flattening anteriorly, so you'll lose that curve. The patient holds the arm adducted and in internal rotation, so they're like this. And usually they can't externally rotate. This is commonly associated with tuberosity and surgical neck fractures of the humerus, a reverse Hill-Sachs. So instead of it being on the posterior side, it's on the anterior side. And injuries to the labrum and rotator cuff. This is one where you can tear your rotator cuff. A CAT scan may be indicated in anybody if you get a plain film and you're like, I think it's out, but I'm not sure. Sometimes you got to get the CT to make sure it's out before you try and do the closed reduction. The techniques are similar to the anterior dislocation. The inferior shoulder dislocations, these ones are harder. These ones are much more infrequent. It's usually caused by an axial loading to the arm with it fully abducted or forceful hyperabduction of the arm. The patient will fall and suddenly grab onto something over their head. Usually how they come in is their arms up here. They can't put it down. The forearm's usually pronated and usually resting on top of the head. About 60% of the patients will have some type of neurological dysfunction. The axillary nerves are most common. It usually resolves once you reduce it. Rotator cuff tears and greater tuberosity fractures occur in about 80% of these people. You can get arterial injuries as well in about 3% of them. So this is an inferior dislocation. You can see it here. The head's way down below the glenoid. So the anterior one, it would be here. So when you're going to reduce it, you can see that the head's up there, so you're going to want to pull from the top. So what you're trying to do is just slide it over the top, and you give the counter traction towards the foot. 5 to 10% of the anterior dislocation reductions in the emergency department are unsuccessful and need to go to the OR. Any displaced greater tuberosity fracture or Bankart fracture that creates a glenohumeral instability usually requires some type of early surgical intervention. The Bankart fracture involves greater than 20% of the area of the inferior glenoid, and it's generally considered critical at that point and requires urgent orthopedic intervention. Posterior reduction X-ray, post-reduction X-rays are usually done. Some people don't do them. I would always recommend them because sometimes you don't have it all the way back in and it feels like it's all the way back in. And it's usually done as a medical legal point to prove that the dislocation was reduced. You always want to check for neurovascular. Because the injuries are rare, but they can always occur. You can get rotator cuff tears in greater than 50% of the patients over 40 with an anterior dislocation. Younger patients, less than 30 years old, are more likely to have a chronic instability. If you do an orthopedic rotation, you'll hear about people having Bankart procedures, which basically what happens is the ligaments tear as well when that you get that avulsion of the inferior glenoid there. So basically what you do is you pull it back up and you use like 3 little screws and you reattach it to give it the same stability as with the ligaments. If you can find the ligament and put it up there, great. If not, you put the articular cartilage and the fracture back on, and usually that's enough. Usually with these people, you want the sling and the swath or the strap that wraps around. You don't want them moving that. Depending on the orthopedic guy, it's anywhere from 1 to 3 weeks before they let them start moving it. There's new theories out there now that the quicker you start moving them, the better off they are. The older guys tend to feel that if you move them too quick, another dislocation could occur more easily. And then what you're going to do is you're going to want them after about a week, 1 to 2 weeks, they're going to start doing those pendulum exercises so that the shoulder doesn't get too stiff. And then you're going to, after about probably 2 to 4 weeks, depending on the person and how much pain they have, you're going to send them and get them into a rehab program with physical therapy. Subluxation of the shoulder, this is when the shoulder goes out and comes back in on its own spontaneously. Usually these are due to chronic unstable shoulders, and a lot of these people can pop their shoulder out and back in on their own. Some people use that as a way to get drugs. I've seen it a few times in the ER. No, they'll come to the ER and they'll pop their shoulder out just before they walk into the ER, and they know that they'll get drugs. So they stand there. You know, they have the little thing out collecting money in the emergency department waiting room, just like down in the train stations. Yeah. Yeah. God, do a trick. These people with these unstable shoulders usually need to have surgery. A lot of times it's a Bankart type procedure like I talked about earlier with the 3 screws. The occult instability of the shoulder is often difficult to diagnose, and a lot of these people have chronic shoulder pain. The only real way to diagnose it is by an MRI. AC dislocations or acromioclavicular dislocations. It's the joint situated at the distal end of the clavicle and its articulation with the acromion. It's a strong joint but a complex joint. Its location is vulnerable to injury, though. Its injuries are classified according to the position with respect to the acromion and the coracoid. You see these a lot. A lot of quarterbacks in football will get these because they'll get hit from their blind side and their shoulder will get driven down into the ground. So the 3 main ligaments of this AC joint, this is your the acromioclavicular ligament right here. This is your coracoacromial ligament. So here's your acromion process here, and here's your coracoacromial ligament and your coracoclavicular ligament. This is your coracoid process, and then here's the wing of the scapula. This picture is not as good. This shows the capsule, though. That's why I put it in there. The capsule's really thin, but it helps to stabilize the joint. So the AC joint is supported by the ligaments that span the anterior, superior, inferior, and posterior aspects. It's held in alignment with the acromion by the strong coracoclavicular ligament. The AC joint itself has a cartilaginous disc and a synovial membrane. There's really no range of motion at that joint. The AC ligament resists anteriorly and posteriorly. The coracoclavicular ligament resists superiorly and axial forces. The roles change if excessive loading forces cause an injury to the AC joint. The coracoacromial ligament provides a secondary stability to the joint and absorbs some of the impact during AC joint trauma. The attachments of the fascia of the deltoid and the trapezius also give some support to this joint. The clavicle kind of acts as a strut that holds the scapula and the shoulder girdle away from the thorax, and that improves leverage in the position of the glenohumeral joint. In the AC dislocations, they're commonly called separated shoulders. You'll hear that quite a bit, and that's talking about the separation of the ligaments. Usually it results from a fall onto the top of the shoulder. The acromion gets driven down, and there's injury to either the acromioclavicular or the coracoclavicular or both ligaments. Usually when you examine these people, there's tenderness and swelling at the joint. Sometimes there's a deformity. Sometimes you'll actually see that the clavicle is sticking up in the air there. Usually that's if the ligaments are completely or nearly completely torn off. So there's different classifications of shoulder separations. In a grade 1, the AC ligament is stretched, but there's no tear to it. It may be a partial tear, but no complete tear. Usually they present with tenderness over the AC joint, mild swelling, but no deformity. Any overhead range of motion and cross-body range of motion are limited. When you look at an x-ray for this, you'll see that the space between the acromion and the clavicle is widened, and you may see a little bit of elevation of the acromion. In the grade 2 tears, there's a complete tear of the acromioclavicular ligament and a partial tear of the coracoclavicular ligament. Typically, it's tenderness and a prominence of the AC joint, and usually there's a lot of swelling with these. In the grade 3 separations, it's complete disruption of both the AC and coracoclavicular ligament. There's usually an obvious deformity with the tenting of the skin from the clavicle, and usually there's significant tenderness no matter where you push at the acromioclavicular joint or if you push across where the coracoclavicular ligament should be. So when you're looking at these, this is a grade 1 separation, so you can see that it's inflamed in that area and is pulled apart a little bit. This is the tear of the AC ligament here. And then in grade 3, there's a tear through both the AC and the coracoclavicular ligament. When you get, this would probably be a grade 3, because if you see how high up the clavicle is in relation to the acromion process here, this would probably be a grade 3 AC separation. Usually it belongs down here. The top of the acromion usually comes along and is even with the top of the clavicle. Usually maybe a couple of millimeters higher. The clavicle might be a couple of millimeters higher, but usually not significantly higher. There's also grades 4, 5, and 6. These are the severe type AC separations. Usually they occur, the grade 4s occur with a forceful shoulder trauma that causes disruption of the acromioclavicular and coracoclavicular ligaments and displaces the clavicle into or through the trapezius muscle, so it starts to push up into the muscle. Usually it's palpable posteriorly. There's a fullness or a deformity to the shoulder despite the swelling. And the sternoclavicular dislocations are common with this. On the axillary view of the X-ray, it'll show that the clavicle is back here. It's posterior. In grade 5, there's significant disruption of both ligaments, along with disruption of the muscular attachments of the distal clavicle. The shoulder seems to be drooping down. There's severe superior displacement of the clavicle with tenting of the skin, so you see the clavicle back here. And the clavicle usually doesn't push down. Usually when you get those grade 3 type separations, if you push on the clavicle, push down and let it go, it'll bounce right back up. It's almost like a diving board, so it springs down and up. In the grade 6 ones, these are pretty rare, but it involves severe dislocation of the AC joint. And these are the ones where the clavicle will be inferior. It will go down, and it will be in the axillary area. These are the ones that need urgent relief because the pressure can be on the neurological bundle and create neurological injury. So the treatment with the grades 1 through 3 is usually conservative, using a sling, ice, immobilization for anywhere from a couple of days, 3 to 4 days to 3 weeks. Usually you cut pain medication with these for 2 to 5 days, and you always want to send them to orthopedics. Usually it's based on how much pain the patient can tolerate or when they start to let you do different things. You want to begin the range of motion exercises as soon as possible, and then you progress to strengthening and stretching. For that, sometimes you have to send them to physical therapy. A lot of times they can return to their normal activities in about 6 to 12 weeks. Athletes may be sooner. Surgery in the grades 1 through 3 are usually only done for cosmetic reasons because the patient doesn't like the clavicle sticking up in the air there like that. A lot of the grade 4 through 6 require surgical intervention. Soft tissue disorders of the shoulder. There's rotator cuff injuries. The rotator cuff injuries include tendonitis, calcific tendonitis, impingement syndrome, rotator cuff tears. With the labrum, you can have labral tears. There's slap tears and there's Bankart tears. Bursitis, capsular dysfunction is adhesive capsulitis and frozen shoulder syndrome, as well as occult instability of the shoulder. And the biceps tendon, you can either get tendonitis, tenosynovitis, or a biceps tendon rupture. In rotator cuff tendonitis, this is a pretty common complaint. It can occur at any age, but it's especially in those that are engaged in overhead activities, pitches, javelin, shot putters, things like that. Usually there's edema and inflammation of the cuff, and sometimes there's micro tears in the tendon. Usually get a thickening of the tendon with inflammation as it overlies the bursa. Most of these people will have tenderness in the subacromial space. So if you push in here, they'll have tenderness to palpation. The pain in the shoulder radiates to the upper arm, usually in this triangle of the deltoid, so the inferior aspect of the deltoid. Anywhere in there, a lot of times it's rotator cuff radiation. The pain is worse with any kind of overhair activity, putting on your shirt, brushing hair, also with internal rotation as well. The pain is a lot of times, like I said, lateralized to the deltoid area. And most of these people complain of pain being worse at night when they lay on that shoulder, and that's because they're compressing that shoulder. So the physical exam with this, With the rotator cuff tendonitis, they get a sunken appearance in the scapular fossa, so right up in here. And that's due to the supraspinatus and infraspinatus atrophying. Usually they'll get tendinous palpation, subdeltoid bursa, subacromial bursa in that area there. The range of motion, it can be limited because of the pain. Usually with abduction and internal rotation is the most, and sometimes when they get further up with flexion. When you do testing for this, you want to do supraspinatus testing, so you can either have them abduct their arm out to 90 degrees and try to push down, or if you want to keep their elbow flexed and abduct to 90 degrees and try to push down. If they can resist you, usually their cuff is intact. If you think you're not strong enough to push their arm down, even if their cuff is torn, if there's a stool in the room, have them pick up the stool and then have them abduct, strict abduction with the stool in their hand. Most of the people, if their cuff is torn, throw their arm up there, so they use their back muscles and their hip muscles. The way you treat rotator cuff tendonitis is rest, to avoid all provocative type injuries, activities rather. A sling, yes or no. The thing you worry about is will they stiffen up in the sling. There's also, should begin gentle range of motion, and then if they need PT, a lot of times ice, non-steroidal anti-inflammatories help take down the inflammation. Anybody that doesn't respond to this in probably by 4 weeks, you should send them to the orthopedic guys and they'll give them a cortisone injection, and usually it'll resolve with the cortisone injection. You may have to modify what they do. If you got somebody who's a painter or somebody who does a lot of overhead work like electricians, things like that, they may have to start using ladders and getting higher and paint in front of them, because that's going to aggravate the tendonitis. Yeah. Frozen shoulder, they can't move. It's all planes pretty much, yeah. Yeah. And it's severe limitation. People with rotator cuff tendonitis usually can get the first 30 to 40 degrees of abduction okay. It's getting past that. So. With calcific tendonitis, pretty much presents in the same way as the rotator cuff tendonitis, and the physical exam is pretty much the same, except they may be a little more tender and a little more painful with range of motion. Usually you'll get an x-ray and you'll see the calcific deposit. It usually shows up as an increased area of density over the supraspinatus. So if you look here, this is where your supraspinatus is coming in to attach. There's the calcification. In these steroid injections, cortisone injections, most people use 40 milligrams of Kenalog along with 2 cc's of 1% lidocaine. So they feel great when you first give it to them, but that's the lidocaine, numbing the joint. Lidocaine's going to wear off in about 2 hours, and the pain will come back. Usually it's about a week before you know whether a cortisone injection is going to take. Usually the calcific material will resorb spontaneously. In some cases, you need to go in and do what's called a subacromial decompression. So you'll go in and you'll knock off the inferior aspect of the acromion process and the distal end of the clavicle, like 2 or 3 millimeters of the distal clavicle, and you'll open up that subacromial space, so that gives that tendon more room to move around in there, and it doesn't hit up against the AC joint as much. And a lot of times what you have to go in and you have to needle the calcific deposit and break it up so that it'll get resorbed. Impingement syndrome, it's the most common cause of shoulder pain. It's attributable to the compression of the structures around the glenohumeral joint. So a lot of times what it is you'll see these spurs off of the inferior aspect of the acromion. So any upward movement of your arm makes the rotator cuff tendon go up. As it hits that spur, it creates pain. Over time, it'll get inflamed, and it can create tears, and it can even create full thickness tears of the supraspinatus tendon. A lot of times these people will have tenderness at the subacromial bursa as well as the subdeltoid bursa and at the long head tendon of the biceps. Risk factors include any repetitive activity at or above the shoulder level during work or activities, and usually some instability of the glenohumeral joint and scapular instability. The presentation is similar to people with tendonitis. Usually the pain is localized in the deltoid area, and it's worse when they're sleeping on it. The throwing athletes complain of stiffness and pain in the posterior shoulder, so as they bring the ball back to cock it and then come forward, that's when they start to feel the pain, because the rotator cuff helps to decelerate your arm as you're coming through. In some athletes, they'll complain of pain with the follow-through, so it's variable. Again, the physical exam is pretty much the same, but you can see much more atrophy of the shoulder muscles with this than with the others. Usually their strength is normal, though, because they'll use other muscles to help with the strength. When you're doing some x-rays of these, in the initial phase, it's only indicated with any type of traumatic injury, but a lot of times the primary cares will send them for an x-ray because they're going to refer them to orthopedics, and the orthopedic guys like to have the x-ray, otherwise they're just going to do one in the office. Sometimes if you think the cuff is torn, you need to get an MRI. MRIs are expensive, so they're trying to get you to cut back on the number you do, but a lot of the primary care guys don't know a lot about orthopedics, so they just scan and refer. So if you look here, this is a little bit dark, but if you look down here, you can see some spurring right down here and across the bottom half of the acromion, the clavicle, and spurring here at the acromion process. So the rotator cuff tendon comes right in through there and inserts here. So any type of overhead movement, you're taking that tendon and driving it up into those spurs. So over time, it's going to start wearing it away. There's 3 stages of impingement syndrome. In the first stage, there's some edema and what's called hemorrhage, or you'll bleed a little from the sharp edges pushing into the tendon. It usually occurs in patients that are less than 25 years old, so this is your athletes, the pitchers, or painters, anybody doing a lot of overhead work. In stage 2, you get fibrosis and tendinitis, and the patients are usually a little older, 25 to 40. Stage 3, which is the most common, occurs mostly in people over 40 years old. Their rotator cuff starts to get wear and tear, and usually these people have had at least one occurrence of stage 1 or stage 2 earlier in their life. Again, the treatment is usually conservative, non-steroidals, ice, rest. Usually only a short course with non-steroidals. You probably don't want to go beyond 10 days, 14 probably max, just because this is detoxed in the kidney. And you get a lot of younger people that figure, well, if 1 is good, 2 is better. And they're really not doing themselves any good. They're not doing themselves any favor. All they're doing is taxing their kidneys. But I've seen it plenty of times. They'll come in saying, that they took 2 or 3 800 milligram Motrins at one time. You're only supposed to take 3 in a day. Maximum amount of Motrin is 2,400 milligrams in a day. So if they're taking 2 or 3 at a whack 3 or 4 times a day, they could be doing damage to themselves that they don't really know down the line. A lot of times the definitive way to treat these is with a steroid injection, especially with impingement syndrome. And the true definitive treatment is a subacromial decompression. And that's like I talked about, where you go in and basically it's done by scope. You knock off the inferior aspect of the acromion and about the first 2 to 3 millimeters of the clavicle to open up the space. If they have any type of rotator cuff tears, you can put anchors in and repair the tear at that time. Also, it gives you direct visualization of the joint. Right. But usually you get, with the shoulder, if you give the cortisone injections, you're probably going to get about 3 months out of it if they work. At least 3 months out of it. Right. So those are probably the people that are going to end up having surgery. Some people come in, they'll get 1 or 2 cortisone shots a year and they're good because they don't want to have the surgery. The surgery is very painful, the recovery, because you can't lay flat. Most people are uncomfortable for at least a week after they have a subacromial decompression. Not true. Well, maybe you're supposed to, but... Yeah.
Question, Manchester?
Right. That's why you're almost better off to send them to the orthopedic guy. Yeah. Rotator cuff tears, there's usually two types. There's the acute traumatic tear, that's from falling on an outstretched hand or grabbing onto something while you fall. The pain's usually acute and gets referred to the deltoid area. They have significant pain when sleeping on that side. The degenerative tears are the ones I just talked about after the impingement syndrome and that come on over time. In the acute rotator cuff tears, the range of motion is usually only somewhat limited in partial tears, but there's definitely weakness in some range of motion, especially abduction. The partial tears can heal themselves within 6 weeks if they're small, but if they don't improve, then they're probably, at 6 weeks, they're probably not going to heal themselves. The X-ray usually doesn't tell you much because you're not going to see soft tissue structures. The MRI is the gold standard now, but you probably need gadolinium with this to light it up. If people that have pacemakers or internal implanted defibrillators, then you can't get an MRI on them, so you've got to send them for a CT shoulder arthrogram. So this is an MRI picture of a rotator cuff tear. You can see the tear through here, the black part. The white part here is fluid, it's inflammation. The treatment for these in partial tears, you treat them like tendinitis, and sometimes they resolve on their own. Sometimes they progress and become complete tears. Usually in a complete tear, depending on the age group, the younger people tend to like to get them fixed. The older people just live with it. Post-operatively, the patients usually require a sling for anywhere, depending on the surgeon, anywhere from 2 to 4 weeks. The guys that do the open ones that aren't comfortable doing them by scope usually keep them in the sling a little longer. Then they begin gentle range of motion and then strengthening and stretching. A lot of times these people have to go to physical therapy because they have some stiffness in the shoulder, especially the open ones. The degenerative rotator cuff tears are usually seen in people older than 40. The symptoms are similar to the acute tear or the impingement. The X-ray can be helpful. Remember, I showed you that one where you see the humeral head riding high because you'll get that loss of the normal subacromial space. Some of these people will require surgery as the definitive treatment, but some people are just willing to live with it. So this is, again, see how high the head is sitting in the joint. That's probably a degenerative type rotator cuff tear. There's disorders of the labrum. The labrum is the cartilage of the glenoid. The shoulder is the most mobile joint and the glenoid shallow, so the labrum provides some stability while without compromising mobility. Usually the anterior dislocation can tear the labrum, and that's the Bankart lesion like we talked about earlier. This creates a positional instability, and they don't usually heal on their own. Usually the most obvious finding on an exam of a Bankart lesion is a positive apprehension test, so it feels like your shoulder's going to dislocate, or the relocation sign. There's also what's called SLAP tears. SLAP tears stand for superior labral tear from anterior to posterior. These occur when there's damage to the superiormost aspect of the labrum. Symptoms are similar to rotator cuff tears, tendinitis, and impingement syndromes. When you examine these people, when you do their shoulders, you want them to hold their arms out with their palms up at 90 degrees, and then you take your hands and put them on their hands and push down. Somebody that has a labral tear, a SLAP tear of the labrum, when you push down, they'll just go right down because they don't have any stability there to hold it up. So here's a SLAP tear, is up here at the top, and then here's the Bankart tear down here from 3 to 6. So this is you can't really see it good on this picture, maybe a little bit better here. You can see the Bankart lesion here. And then here's the SLAP tear right here at the superior aspect. This is a better picture here. You can really see the SLAP tear of the labrum. The definitive treatment for Bankart and SLAP tears is usually arthroscopic repair. You correct the instability, and then 2 to 4 weeks in a sling and a swath. You really don't want them moving around too much because you've put anchors in to hold these back in place, and then you're going to send them to PT for range of motion and strengthening. Some patients with unstable shoulders have problems with an overly lax capsule, so it's going to feel like it's popping out on them. They have similar symptoms, but they haven't had the dislocation or the subluxation. Usually what you do with these people is you do what's called a capsulorrhaphy, where you basically go in with heat and shrink the capsule so that it tightens the joint up. The risk with that is that you create a frozen shoulder afterwards. So it's a kind of a controversial type surgery right now. Bursitis is similar to impingement syndrome, either the subacromial bursa or the subdeltoid bursa. It occurs mostly in patients over 40. Most of these people are treated conservatively, NSAIDs, ice, rest, but it can lead to an impingement if it becomes chronic. Frozen shoulder, it's defined by the American Association of Orthopedic Surgeons as a condition of varying severity characterized by gradual development of global limitation of active and passive shoulder motion, where radiographic findings other than osteopenia are absent. Usually it occurs after a shoulder injury or some type of extended immobilization. It's also referred to as adhesive capsulitis. However, people with adhesive capsulitis usually have more pain than people with frozen shoulder. It happens in about 2 to 5% of the population. Women are more common than men and usually over 40 years old. It's predominantly one shoulder. It can happen in both, but it's predominantly one shoulder. Risk factors include diabetes, thyroid disease, stroke, autoimmune diseases, Parkinson's, and use of antiretroviral therapy like HIV-positive type patients. The pathophysiological process involves thickening and contraction of the glenohumeral joint capsule and the collagenous tissue surrounding it. So it reduces the volume of the joint, so it reduces your range of motion. Usually in the clinical presentation, they're having some pain in the shoulder, and it's diffuse and severe. You can't really localize the pain when you examine them. The pain gets worse at night, and the stiffness is worse usually over the last 2 to 9 months. In the intermediate phase, they're more stiff, and there's severe loss of shoulder range of motion. The pain is gradually less, and it lasts about 4 to 12 months. The recovery phase is they get a gradual return of their range of motion. Sometimes these resolve spontaneously, and it takes about 5 to 24 months. So on physical exam, it's a stiff, painful joint. It makes it really difficult to perform a good exam on these people. Usually there's significant reduction in active and passive range of motion in 2 or more planes. External rotation and abduction are the 2 most affected. Usually these people have a hard time putting their hand behind their back, like reaching into your wallet, or reaching in behind like this onto their back. Usually attempts to move them past their restriction are painful and they resist you. A lot of times the pain is less if you give them some if they're doing isometric strength testing. So we're testing their cuff in abduction. Usually you're not going to see anything on diagnostic imaging. The treatment is usually physical therapy. You restore the motion, you gradually decrease the inflammation in the capsule. It's a slow process. I've seen these people when I worked in orthopedics, it take up to 6 months for them to get about 75% of their range of motion back. So it's a variable presentation. The patients with true adhesive capsulitis usually don't benefit from PT until they're out of the inflammatory phase. In some cases, you take them to the OR and you put them to sleep and you rupture the adhesions just by taking their shoulder and moving it through quick range of motion, so you can basically hear the adhesions tearing. The drawback to that is the adhesions can reoccur. And usually the only people you do this on is people that don't respond or have very limited response to conservative treatment. Some people give intra-articular steroid injections and say that they have some benefit. The guys that I work for think that they have limited benefit. But some people swear by them, and that's their first treatment even before they send them to PT. Biceps tendonitis, or tenosynovitis, is an inflammation of the long head of the biceps tendon and the tendon sheath in tenosynovitis. These patients present a lot like rotator cuff tendonitis, but they'll be tender over the biceps tendon when you push on it. Usually you find that in the bicipital groove. The pain is reproduced with the elbow flexed to 90 degrees and the forearm supinated against resistance. So if you flex them to 90 degrees and have them try and turn against you, because that's what the bicep does, it supinates. So you'll put a lot of pressure on that long head tendon. The treatment is the same as shoulder tendonitis, rest, ice, activity modification. Non-steroidals may be helpful. You can do a steroid injection into the tendon sheath if they don't improve with conservative treatment, but most of them do respond to conservative treatment. Biceps tendon rupture. This occurs mostly in men over 50. These are the guys that you see that it looks like they have the Popeye bicep, the Popeye muscle there, because the tendon will rupture and it'll shrink up. Usually they note a pain or a snapping sound or sensation when it happens. The diagnosis is pretty easy because you can see it. The bicep just curls up. There's no real conservative treatment. You're not going to fix this conservatively. When the tendon snaps, it's down there. In people over 50, you tend to see if they can live with it. In the younger people, they're going to want it fixed because they're going to be much more active and they're going to need that. Some people just don't like the way it looks and they want it treated cosmetically. Osteoarthritis, or DJD of the shoulder joint, that occurs when the articular cartilage wears out. There's usually limited shoulder motion. It occurs gradually, but eventually becomes quite fixed and frozen. There's crepitus, or grating feeling when you put your hand over the shoulder and move them back and forth. It's usually tolerated better than most types of osteoarthritis because it's not a weight-bearing type joint. X-ray shows collapse of the joint space, osteophyte formation, and a deformity, or sometimes cystic type deformity of the humeral head. Usually the treatment's conservative. In this case, you can't give a cortisone shot in the office to help with the inflammation of this. You have to send them to interventional radiology, and they have to pass a catheter into the joint and give an intra-articular steroid injection for that. Some cases, these people are going to need an arthroplasty or joint replacement or reverse shoulder arthroplasty if their rotator cuff is torn. So you can kind of see here, see all the osteophyte formation. There's the loss of the joint space. This is spurring down here. This just shows you, kind of highlights it. This is a shoulder arthroplasty. This is the reverse shoulder, which is kind of weird because usually it's the ball going into the cup in the joint. Now what they've done is they've taken the ball and put it with screws into the cup, and they've made the joint here out of the prosthesis. So it kind of rotates. There's a bunch of these out there. There's one that even looks like a track, and it levers in the track. Osteolysis of the AC joint, or AC joint DJD. It's seen in weightlifters, so they're the guys lifting a lot of weights above the head. It's lysis of the distal clavicle that affects the AC joint. Unlike other shoulder pain, the patient will point directly at the AC joint when you ask them to localize the pain. When they lift their arm, it impinges the AC joint and causes pain. There is usually point tenderness or palpation at the AC joint. X-ray is going to demonstrate osteolysis of the distal clavicle. The diagnostic test is to inject lidocaine and a steroid directly into the AC joint, and the pain usually resolves right away. The steroid can give them months of relief, but usually the pain's going to reoccur. And the definitive treatment is to go in arthroscopically and take that 2 to 3 millimeters of the distal clavicle off. You can do it open, but arthroscopic's better. It's a quicker recovery. And I think that's it. I think I went over, but...